You know the headlines, right? Heart disease is this global behemoth, impacting millions, still a leading cause of death worldwide.
It really is.
But what if we told you that simply knowing what causes heart disease is, well, maybe only half the battle?
Hmm.
What if understanding the intricate pathways, the invisible domino effects that culminate in conditions like coronary artery disease, ischemic heart disease, or even a devastating myocardial infarction? What if that is just as crucial, maybe even more so?
That's exactly it. That's the heart of our discussion today.
Yeah.
We're taking a deep dive into an incredibly powerful, yet maybe often underutilized approach in cardiovascular research. Mediation analysis.
Mediation analysis, okay.
Yeah. Our mission isn't just about identifying isolated risk factors that might lead to heart disease. I mean, that's important, but
Right.
it's really about dissecting the very mechanisms, the crucial intermediaries that connect in initial exposure, whatever that might be, to its ultimate outcome.
Like peeling back the layers of an onion.
Exactly. Revealing that precise sequence of events unfolding within our bodies or even in our environments.
And to really get to grips with this, we've been pulling insights from, well, a really rich collection of epidemiologic studies.
Mm-hmm.
We're talking everything from long-term prospective cohorts, following thousands of people for decades, to population-based observational studies capturing real-world patterns.
All right, the big picture stuff.
Targeted case control studies zooming in on specific conditions, and even those cutting-edge Mendelian randomization studies that use genetics to try and uncover true cause and effect.
Yeah, those are powerful.
So this deep dive, it's really designed to give you, our listener, a shortcut to being truly well-informed about this, well, complex dance of factors leading to heart disease.
So what can you expect?
Mm-hmm.
We're going to systematically unpack the different types of mediators we've identified in these studies.
Okay.
This includes everything from tiny biological markers circulating in our blood to the everyday choices we make, the environments we live in, and even how medications actually exert their effects.
Right.
Our goal is to clarify not just that an association exists, but how and why it matters, and where the science is headed next in this absolutely fascinating field.
Okay, let's unpack this then. Our first stop has to be truly understanding the power of mediation analysis itself. Why is it so revolutionary, maybe? And why is it, as some experts suggest, still an underused approach to cardiovascular research? Seems like it should be everywhere.
It's a really fundamental question. At its core, mediation analysis is it's a statistical method. It's designed to identify and quantify the specific steps, what we call mediators, by which an initial exposure or factor causes a health outcome.
Okay.
So instead of just observing that, say, living in a highly polluted area, let's call that A, is linked to a higher risk of heart attack, C.
Right, the simple connection.
Mediation analysis lets us ask, does A lead to B, maybe chronic inflammation, and then does B, that inflammation in turn lead to C, the heart attack?
Oh.
If that's the case, then B, the inflammation, is our crucial mediator in that specific causal pathway.
So it's not just drawing a line between two things, it's drawing the entire causal chain. Like finding out that eating too much sugar, A, doesn't just maybe directly cause heart disease, C.
Right.
Maybe it first causes high insulin levels, that's our B, and then those persistently high insulin levels contribute to heart disease. You're mapping the journey.
Precisely. And the methodologies used to uncover these pathways, they're quite sophisticated. We're talking techniques like causal mediation analysis, path analysis, structural equation modeling.
Sounds complex.
They are. These aren't just simple correlations. These tools are built to untangle complex, often multi-directional relationships. They help reveal the underlying causal mechanisms, not just surface-level associations.
So they help confirm the direction and how much goes through that middle step, that mediator.
Exactly. They quantify how much of the effect is transmitted via the mediator.
So if it's this powerful, why the underused label? I think it was Redfers and Lynn in 2020 who mentioned that. Why isn't it the gold standard already?
Well, it's a valid point. Part of it might be the complexity, like you said. It requires not just robust data, but also really careful thinking about the underlying causal assumptions.
Okay.
And while it's definitely gaining traction, there's still immense room for growth. But its true value, it lies precisely in providing that more comprehensive, nuanced understanding of both biological processes and the social dynamics impacting health.
Right.
Think of it like trying to solve a puzzle with only the edge pieces. Mediation analysis helps fill in the middle, revealing how things are connected. And crucially, it guides us on where we might intervene most effectively.
And for us, the learners, the listeners, this translates into something really actionable, doesn't it? It shifts how we think about prevention.
Precisely. Knowing these mediators allows for much more targeted interventions and prevention strategies. If we understand how a risk factor operates the specific pathways it affects, we can design interventions to interrupt that precise mechanism.
Makes sense.
So for you, the listener, it means gaining a deeper, more actionable understanding of heart health. Moving beyond just knowing the risk factors to understanding the specific levers we might pull for more effective prevention or treatment, whether that's personally or, at a public health level.
That truly makes perfect sense. Knowing the how gives us a much clearer roadmap. So let's dive into some of those specific hows, starting with the body's own signals, the biological pathways leading to heart disease, and lipids, lipid metabolism pathways. They seem like a huge piece of this.
Indeed, they really are. One marker gaining a lot of attention is the triglyceride glucose index, or TIG index.
TIG index, right.
This isn't just another lab value. It's a powerful, pretty accessible proxy for insulin resistance, which is such a fundamental metabolic issue. Studies have shown its strong correlation with a whole spectrum of cardiovascular outcomes, total CVD, congestive heart failure, angina pectoris, even acute myocardial infarction.
Wow.
In fact, some research, like work from Dang and colleagues, suggests that when you combine it with waist-to-hip ratio, the TIG-WHTR combination actually correlates best with myocardial infarction.
That's fascinating. It zeroes right in on heart attacks. And I saw the TIDE index isn't just broad. It's linked to the severity of coronary artery disease across different glucose metabolism states. So whether you have prediabetes, diabetes, or normal glucose, it still gives insight.
Exactly. It cuts across those categories.
And it's not just overt symptoms. It's connected to silent myocardial infarction, too, those heart attacks you might not even know you've had. Plus, that surprising inverse association with serum magnesium and calcium in CAD patients, that adds another layer, suggesting a wider metabolic imbalance, doesn't it?
It absolutely does. It points to how multifaceted this index is, highlighting underlying metabolic dysfunction that can manifest in various ways, from silent damage to major heart events.
Okay, so TIG index is key. What else in the lipid world?
Well, moving on, lipoprotein, or LPA, is another crucial player.
Ah, yes, LPA. Hear more about that lately.
You do. And unlike other cholesterol markers, which can be significantly influenced by diet and lifestyle, LPA levels are largely genetically determined.
Right. That's the key difference.
It is. It's a cholesterol-carrying particle consistently associated with increased risk of myocardial infarction. Now, the precise mechanisms are still being fully worked out, but we know it's linked to high-risk coronary disease attributes like increased total plaque volume, even a specific fat attenuation index around the arteries, which indicates inflammation and unhealthy fat deposits.
And what's really powerful here, isn't it, is that it's not just a marker. It seems to be a mediator we can actually target, like with the drug evolocumab.
Exactly. It's a fantastic example. Evolocumab is a PCSK9 inhibitor, and research showed it significantly reduces pericoronary adipose tissue density, that harmful fat building up around heart arteries. And mediation analysis revealed something remarkable. LPA, specifically, mediates a huge chunk, 69.8% of that relationship.
Wow, nearly 70%. That's incredibly precise. It shows exactly how the drug works on that specific pathway.
It's a textbook example of mediation analysis informing treatment mechanisms with impressive clarity. Then, of course, we have HDL cholesterol.
The good cholesterol.
Classic good cholesterol. It plays key mediating roles, too. For instance, it helps explain part of alcohol's documented protective effect on coronary heart disease, something observed decades ago.
Right. Now, that doesn't mean everyone should start drinking.
Definitely not.
Yeah.
But it helps explain a known epidemiological observation through a specific biological mechanism. Similarly, statin therapy, cornerstone of prevention, increases HDL levels, which in turn decreases the probability of coronary artery calcification, that hardening of the arteries.
So HDL isn't just correlated with better health, it's actively mediating these protective effects in some contexts. I also saw it's involved in how cholesterol levels mediate the effects of sex hormone-binding globulin on CHD risk, another complex link.
It highlights that hormonal metabolic connection, yes. And for those already with CAD, it's not just the amount of HDL, but its quality, specifically its antioxidative capacity, that's relevant for predicting major adverse cardiovascular events.
So functional HDL, not just high HDL.
Exactly. Function matters. The complexity deepens when we look at apolipoproteins like ApoA1 and ApoB.
Okay, the protein component.
Right. The proteins on the surface of lipoproteins. Their levels and ratios are associated with blood pressure in CAD patients, showing a broader systemic impact. Furthermore, genetic variations in APOA5, a gene regulating triglyceride and HDL metabolism, have shown causal effects on premature CAD, meaning certain genetic setups can directly lead to early heart disease through their impact on these proteins.
Directly causal. Okay.
And levels of APOC3 are also causally linked to CAD risk, though the exact mechanism for that one is still, well, largely unknown, an active area of investigation.
It really is like an ongoing detective story, constantly uncovering these connections. And speaking of uncovering, what about remnant cholesterol? Sounds like leftovers, but it's significant.
It is, and it's gaining increasing recognition. Remnant cholesterol is basically the cholesterol carried in partially metabolized triglyceride-rich lipoproteins, the leftovers, after our body processes fats.
Got it.
It's strongly linked to unhealthy lifestyles and increased risk of coronary heart disease and myocardial infarction. And what's critical here, chronic inflammation has been identified as a key factor, potentially mediating its harmful effects.
Inflammation again.
Yes. And remnant cholesterol is also specifically identified as a mediator linking obesity to ischemic heart disease. It provides a clear pathway. Obesity leads to these dysfunctional lipid profiles, which then trigger inflammation and heart disease.
That brings us perfectly to our next big category of biological mediators, inflammatory markers. Inflammation is such a huge topic, and in heart disease, it's understood to be a major pathway. Right?
Absolutely central. Think of interleukin-6, IL-6, and C-reactive protein, CRP, fundamental inflammatory markers. They play important roles in linking conditions like chronic periodontitis, severe gum disease with coronary artery disease, shows that systemic inflammatory link.
Right. Connects the mouth to the heart, essentially.
It does. And beyond that, advanced genetic techniques show that genetically proxied IL-6 signaling impacts atherosclerosis, but it's mediated by other specific factors like CXCL10. It reveals a downstream chain of inflammatory events.
A cascade effect.
Precisely. And high-sensitivity CRP, hsCRP, is widely recognized. Strongly associated with coronary atherosclerosis, powerful enough to predict 10-year cardiovascular events, even in patients with rheumatoid arthritis, where chronic inflammation is just part of the disease.
So it's predictive, not just correlated. And systemic inflammation connects other things too, like liver fibrosis, liver scarring to CAD severity.
Yes, it mediates that link. And crucially, it explains a significant portion of the increased CAD risk from obesity. That's a huge takeaway. Inflammation is a central player, a key mediator connecting various upstream causes to the ultimate heart disease outcome.
It really seems to be a common thread.
It is. And another intriguing mediator, a very specific type of fat, is paracoronary adipose tissue, PCI. Attenuation.
PCEC, fat around the heart artery.
Exactly. And its attenuation, or unhealthy changes, indicates inflammation and dysfunction right there. Mediation analysis showed this specific fat mediated a significant 31.66% of the correlation between insulin resistance and coronary inflammation in CAD patients.
Over 30%,
Yeah.
just from that fat layer.
Yes, it's a localized inflammatory process happening right around the heart's blood supply, playing a very substantial role.
And of course, smoking. It always comes up. It works through inflammation too.
Absolutely. Smoking exposures consistently associated with increased CRP and IL-6. Plus, IgE, usually known for allergies, is surprisingly implicated in acute myocardial infarction pathogenesis, and smoking increases IgE levels. So it's not just direct damage from smoke, it's this profound systemic inflammatory response rippling through the body.
Just sets everything off. Okay, moving from inflammation to our fundamental blueprints, genetic biomarkers and predispositions. How do our genes mediate risk?
Well, it's fascinating. Genetic susceptibility can actually modify how things like artificial sweeteners impact cardiovascular disease risk.
Really? So my genes affect how I react to sweeteners?
Potentially, yes. It means our individual genetic makeup influences how our bodies respond to environmental factors, altering whether something is harmful or not for us specifically.
That highlights the complexity of individual variation, and things like PCOS, polycystic ovary syndrome. The genetic risk factors can cause non-reproductive issues independently.
Yes, suggesting deeper systemic genetic influences impacting metabolism, cardiovascular health, extending far beyond just ovarian function.
Wow. And specific genes are emerging as causal factors or mediators.
Definitely. For instance, Golgi protein 73 has been identified as a causal factor for coronary artery disease. Opens up new research avenues.
Okay.
We also know CXCL10, that signaling protein, is a downstream causal mediator for IL-6 signaling on atherosclerosis, reinforcing that chain.
Yeah.
Inflammation leads to plaque. And genetic variations in CCL17, another signaling molecule, are also linked to CAD risk.
And it's not just genes for specific proteins. I saw a link between genetic liability to multi-site chronic pain and higher CAD risk. That seems unexpected.
It does. But it highlights the systemic nature of pain and its potential connections to underlying inflammatory or neurological pathways that also impact heart health. Speaks to the profound interconnectedness of our systems.
Incredible. What about early life factors like birth weight?
Also intriguing. Surprisingly, research found birth weight can have opposite causal effects on myocardial infarction versus atrial fibrillation, operating through distinct mediating pathways.
Opposite effects. So low birth weight might increase risk for one but decrease for another through different routes.
That's what the evidence suggests. And lower birth weight generally is linked to poorer cardiovascular health in middle age, suggesting that early life programming has long-lasting mediated effects.
Amazing how early life sets these trajectories. I also saw certain sodium glucose cotransporter 2, SGLT2 variants, are associated with heart failure even in people without type 2 diabetes or established CAD.
Yes, suggesting a direct genetic predisposition to heart failure that isn't always linked to the typical diabetes or CAD pathways. It expands our understanding of heart failure origins, highlights how genetic predispositions can act independently.
Right. And on a molecular level, G protein-coupled receptor 15, GPR15 expression associated with MI.
Correct. Suggests genetic predispositions influence heart attack risk beyond just the lifestyle factors we often focus on.
And within the cells themselves, mitochondrial DNA deletion, the cell's powerhouses.
Right. Specifically, the 4977 base pair mitochondrial deletion, a specific genetic glitch, may play an important role in CAD, especially in type 2 diabetes patients, particularly when interacting with folate deficiency.
Wow, a specific deletion plus a nutrient deficiency. Very precise.
It's a very precise example of how cellular energy function plus nutritional status can contribute to heart disease, linked to this idea of biological age.
And speaking of aging, that brings us to aging-related biomarkers, like DNA methylation age acceleration.
Yes, a healthy lifestyle is associated with DNA methylation age acceleration, a measure of biological aging, which in turn influences the incident risk of coronary heart disease. So lifestyle impacts aging speed, which mediates heart risk.
And the physical manifestation, arterial stiffness.
Absolutely critical, associated with aging and high blood pressure. It's a crucial mediator in developing myocardial infarction, stroke, and atrial fibrillation. It's not just a sign of aging, it's an active contributor increasing heart workload, damaging vessels.
Okay, so we've seen internal signals, genetics, aging. Now let's shift focus to our daily lives and medical conditions. Lifestyle and clinical risk factors. Obesity is obviously a huge one. How does it mediate heart disease exactly?
Well, obesity and high BMI are consistently linked to risks like venous thromboembolism and MI. But mediation analysis helps clarify if obesity itself is the direct cause or if it mediates risk through shared underlying mechanisms. It's not always straightforward.
That's a really key distinction. Like with metabolically healthy obesity, MHO, high BMI, but no overt metabolic issues, it's still linked to coronary artery calcification.
It is, but
That link gets weaker when you adjust for underlying metabolic risk factors, suggesting those factors are the real mediators, not the weight itself in those cases.
Exactly. It redirects our focus to the underlying metabolic health, the true driver. BMI's own mediating role has also been looked at for things like serum uric acid and cardiovascular diseases, showing its broad influence.
And the type of fat matters, right? Visceral adipose tissue, the deep belly fat.
Crucial. It independently predicts and mediates the progression of coronary calcification. This type of fat isn't passive. It's active, secreting hormones and inflammatory molecules that directly contribute.
And back to inflammation, it mediates a significant part of the increased CAD risk from high BMI.
Yes. So it's not just weight, but the inflammatory response it triggers. And perhaps surprisingly, obesity-related factors also influence erectile dysfunction, partly mediated by underlying coronary artery disease. Highlights that systemic impact again.
Powerful systemic effects indeed. Let's move to diabetes and metabolic syndrome, closely intertwined with heart health. What about type 1 diabetes, T1DM?
For T1DM, or an autoimmune condition, hypertension partly mediates its causal effects on atherosclerosis. About 11.5% for peripheral, nearly 17% for coronary atherosclerosis. So high blood pressure is a critical bridge, a key mediator to arterial damage in T1DM.
And gestational diabetes, GDM during pregnancy, lots of long-term mediated effects there too.
Absolutely. Strong genetic correlation with later CAD and MI. Cardiometabolic factors partially mediate the link between GDM and higher long-term CAD stroke risk. Other factors, like later T2DM, also mediate its future CVD risk. It's evaluated considering T2DM and shared environmental familial factors as mediators, a complex web highlighting long-term impacts of pregnancy complications.
Really underscores the lasting effects. Now, type 2 diabetes, T2DM itself.
Widely seen as a causal risk factor for CAD, though the intrinsic molecular links are still being fully mapped out. Also a known risk factor for atrial fibrillation.
Which brings us to insulin resistance, IR, often preceding T2DM.
Right. IR is strongly associated with CAD severity, and that paracoronary fat, PCA attenuation, it mediates about 31.66% of this correlation. Another clear mechanism. IR impacts the fat right around the heart. It also affects coronary lesion complexity and prognosis in acute coronary syndrome, critical factor in heart attack severity.
And the broader picture, metabolic syndrome, that cluster of risk factors.
Clearly associated with CAD severity. Structural equation modeling studies reinforce this, suggesting a common underlying pathophysiology, like a constellation of issues converging. And interestingly, metabolic biomarkers mediate the role of major depressive disorder on vascular complications in T2DM patients. That metabolic link, again, it really illustrates that deep connection. Next, blood pressure regulation, obviously fundamental. Hypertensive disorders of pregnancy, HTP, like preeclampsia.
Right, unique risks for women.
And with long-lasting effects. Chronic hypertension, often developing after HTP, explains about 6.2% of HTP's contribution to later cardiovascular disease. Importantly, genetically predicted HTP is only partially mediated by cardiometabolic factors, meaning other pathways are likely involved too.
And hypertension isn't just an outcome, it's a mediator itself, acting as that bridge.
Yes. It partly mediates type 1 diabetes effects on atherosclerosis. But even broader, it's a potential mediator for how long-term road traffic noise might lead to heart failure, or MI.
Wow, so the noise outside could impact your heart via blood pressure.
That's the hypothesis being tested. Even systolic blood pressure mediates the effect of early menarche start of menstruation on CAD risk. Shows how early life factors can influence things decades later through a blood pressure pathway.
Fascinating how things converge on hypertension. What about hepatic steatosis, fatty liver disease?
There's a temporal relationship with blood pressure elevation, and it seems to have mediation effect in CVD development. Shows how liver health can impact the cardiovascular system via blood pressure.
Moving to other clinical factors. Depressive symptoms and disorder come up a lot.
Tragically common and significantly associated with all-cause mortality, CVD mortality, specifically ischemic heart disease mortality. And it's not just correlation. Metabolic and immune inflammatory factors mediate its association with premature coronary heart disease.
A critical and growing area. Depression often coexists with CAD, mediates its association with other traits, creating a vicious cycle.
Exactly. It even mediates the link between a cardiometabolic index and suicidal ideation, underscoring severe mental health impacts. And depression mediates the impact of poor sleep traits on cardiovascular disease. Sleep affects mood, which affects the heart.
Wow. And prenatal depression linked to new CVD postpartum, extending across generations.
It has profound impacts. These are powerful, complex psychosocial pathways we're just starting to fully map.
Clearly, mental health isn't separate, and prevention matters upstream too. Preventing CHD events eliminates some of hypertension's effect on heart failure.
Yes, highlights the importance of addressing root causes before they lead to severe outcomes.
What about serum uric acid?
Genetically correlated with BMI, associated with AFib, CAD, hypertension, another biomarker potentially mediating links between diet, metabolism, and heart health.
And fatigue.
Increasingly recognized link to cardiometabolic diseases, being explored with observational and genetic approaches to pinpoint the biological or behavioral pathways involved.
Okay, we've covered a lot internally. But our health isn't just internal. The world around us plays a massive role. Let's talk environmental and social pathways, starting with air pollution.
Major global issue. Long-term exposure to fine particulate matter, PM2.5, PM10, those tiny particles.
Right, the ones that get deep in the lungs.
They don't just harm the lungs. Research shows they lead to mortality mainly through metabolic and cardiovascular disease pathways. PM2.5 specifically mediates the link between long-term exposure and CAD incidence.
So systemic effects, not just lung damage, associated with coronary stenosis too, direct artery hardening.
Yes. And interestingly, residential greenness access to parks. Nature can influence ischemic heart disease risk, partly by mitigating air pollution effects. Suggests environmental quality is a complex mediator.
What about ozone?
Long-term exposure shows complex nonlinear relationships with CVD and ischemic heart disease mortality, meaning it's not a simple more ozone, more risk line. There are thresholds, complex biological responses, often with metabolic mediators involved. Nuance is critical.
That is nuanced. And it's not just air. Noise exposure is emerging too, often overlooked.
Definitely. Long-term road traffic noise linked to incident heart failure, potentially mediated by acute MI, hypertension, or diabetes. So the constant drone of traffic might impact heart health by first affecting blood pressure or metabolism.
That's quite something.
Environmental noise broadly is associated with MI and stroke, with hypertension being investigated as a key mediator. And this isn't just small studies. Nationwide U.S. cohort studies confirm the long-term noise-CVD link.
A stark reminder our surroundings matter deeply. Let's pivot to socioeconomic disparities. Profound influence, mediated complexly.
Hugely. Low income and education linked to worse secondary prevention use and poorer prognosis after MI. Needs deeper digging into mediators, maybe limited access to healthy food, safe exercise spaces, quality healthcare, higher stress. It's what income enables or restricts.
And income level is directly associated with ischemic heart disease, with something like walkability as a potential mediator.
Exactly. Poor sidewalks, no parks that lack of physical activity opportunity, influenced by income and neighborhood, could mediate heart risk. Connects urban planning directly to public health.
Very tangible link.
And causal mediation analysis, using record linkage, helps dissect how broad societal factors translate into individual health disparities through specific behavioral and physiological mediators. Really powerful methodology.
And cumulative social risk reinforces this. Multiple disadvantages compounding.
Yes. Low income, low education, single living status, collectively linked to higher stroke, MI, angina risk. Mediation analysis also assesses direct effects of race and high socioeconomic deprivation on outcomes after surgery, like lower extremity bypass. Shows how societal constructs impact clinical realities.
Underscores that health is shaped systemically, not just personally. Now, behavioral mediators are daily choices, often influenced by environment and society. Smoking.
Classic example. Damages health via multiple mediated pathways, especially through coronary artery disease. Analyzing this involves looking at time-varying exposures, other mediators, confounders, the whole picture.
And it's not just direct lung damage. Lipids are crucial mediators. Triglycerides, cholesterol.
Yes. Studies show lipids are likely mediators. Smoking isn't just a toxin. It's a systemic biochemical disruptor throwing lipid metabolism out of whack.
Right. What about alcohol intake? We touched on HDL.
Yes, HDL mediating part of that historical protective effect. Observational studies suggest complex effects promote or protect depending on quantity, pattern. Mediation analysis helps understand how through HDL or other metabolic pathways. Very nuanced.
Definitely nuanced, not a blanket recommendation. Physical activity and sedentary behavior.
Leisure time versus occupational activity have distinct effects on MI incidence, with mediation and interaction observed. Not just if you're active, but how and where. And excessive sedentary time strongly associated with MI metabolic diseases. Its link to mortality in MI survivors is mediated by metabolic abnormalities. Sitting isn't just fewer calories burned, it disrupts crucial internal metabolic processes.
A deep metabolic consequence, and even walking pace matters, mediated by inflammation.
Yes, brisk walk isn't just muscles, it reduces systemic inflammation. Plus, fascinatingly, genetic liability to sedentary behavior is linked to MI and heart failure risk. Even our tendency to sit can have a genetic component impacting the heart.
Genes, habits, disease, all linked. Dietary patterns, similar mediated pathways.
We see them. Artificial sweeteners linked to CVD risk mortality, potentially mediated by type 2 diabetes. So maybe not the sweetener directly, but the metabolic dysregulation it triggers, leading to diabetes, which then hits the heart.
Right, and dietary fiber.
Robustly linked to reduced inflammation, better CVD outcomes in older adults. Suggests fiber protects partly via anti-inflammatory effects, maybe gut health impacts.
Makes sense. DASH diet.
Associated with lower CAD stroke mortality. Research evaluated specific minerals like potassium, magnesium as key mediators, and general diet quality measures like the Alternative Healthy Eating Index linked to lower MI risk.
So healthy eating works through multiple protective pathways. Lastly, under social factors, social integration and isolation.
Profound role. Social integration belonging, connection strongly linked to reduced CHD risk in women, mediated partly by healthier lifestyle behaviors.
Powerful connection. The flip side. Isolation.
Associated with accelerated death, incident CVD in chronic kidney disease patients. Clear detriment. Associations with ischemic heart disease have been inconsistent sometimes, and the precise biological behavioral mediators are still being actively investigated. Complex area.
It is complex. Social factors influence health through many routes: emotional stress and depression.
Clearly linked. Stress and adaptive behaviors linked to stroke risk, examined via Mendelian randomization for stronger causal evidence.
And adverse childhood experiences, ACEs, linked to adult CHD.
Profoundly. Mediated by psychological factors, depression, anxiety, biological factors, inflammation, and behavioral factors, unhealthy habits. Early life adversity casts a long shadow via these pathways. Even nutritional status in older adults, the Geriatric Nutritional Risk Index, plays a role in MI prognosis. Basic health mediates outcomes, truly emphasizes the comprehensive nature of factors. So we've explored biological, lifestyle, clinical, environmental, social. Let's bring it to how we intervene. Pharmacologic mediation pathways, understanding treatment effects, how meds work by mediating specific changes.
Incredibly important. Moves beyond just knowing a drug works to how it works. Better drug design potential, take statin therapy. Cornerstone medication.
Widely used. Mediation analysis shows statin use increases HDL, which in turn leads to decreased coronary artery calcification. Clear, two-step mediated pathway for reducing heart attack risk.
Beyond lipids, they also influence that paracoronary fat, PCNT.
Yes, another mechanism. However, it's complex. Statins have surprisingly been reported to increase herpes zoster, shingles, incidence, and shingles itself is linked to increased CVD risk. Suggests a mediated side effect.
Wow, a beneficial drug potentially opening another risk pathway shows the complexity.
It's a crucial example of nuance. Even good meds can have complex mediated effects.
What about other drugs working through specific mediation?
Evolocumab we mentioned, perfect example. Attenuates PCA density. And LPA mediates nearly 70% of that relationship. Incredible precision.
Amazing.
For renin-angiotensin system, RAS, inhibition blood pressure meds, research assessed benefits beyond BP lowering and reducing albuminuria, especially in type 1 diabetes. Suggests additional mediated protective mechanisms are being explored.
And for critically ill MI patients, ondansetron, an anti-nausea drug,
may play a protective role partly via anti-inflammatory activity. Similarly, dexmedetomidine, a sedative, shows protective effects in acute MI, partly via anti-inflammatory activity. Highlights inflammation as a common target, sometimes unexpectedly.
Right, drugs hitting that inflammation pathway.
And even for delirium in critically ill asthma patients, montelukast, an asthma drug, shows promise via reducing delirium, partially mediated by that delirium reduction. Fascinating ripple effects through different systems via specific mediators.
We've covered so much ground, micro-level biology to macro-level society and how meds intervene. This brings us to our final section. Advancing the science methodologies and future directions. How do researchers even unravel this complexity?
It truly takes diverse study designs. Many findings come from prospective cohort studies following large groups over long periods. Think Framingham, UK Biobank, China Kadoorie Biobank, critical insights on aging CHD, sedentary behavior MI, GDM long-term CVD, watching dominoes fall over time.
Long-term real-world observation and population-based observational studies.
Essential for real-world impact across diverse populations, broader trends. Examples on noise exposure, green to CVD, obesity. Captures the big picture, prevalence across populations.
And for specific or rarer conditions, case control studies.
Very useful. Investigating migraine and spontaneous coronary artery dissection or occupational exhaust exposure. They work backward from an outcome, looking for exposures and mediators.
But the big game changer for inferring causality seems to be Mendelian randomization studies. Can you explain why they're so powerful for mediation?
Absolutely. MinShare studies are a methodological best practice. They strengthen causal inferences by minimizing confounding that issue where hidden factors influence both exposure and outcome.
Right.
The brilliance is using genetic variants, randomly assigned at conception, like in a trial. If a variant is linked to an exposure, like high LPA, and also to an outcome, like heart disease, and it only influences the outcome through that exposure,
then you have much stronger evidence for a causal link, like nature's own experiment.
Exactly. Harder for hidden factors to muddy the waters. We saw MER examples today, T1DM and CVD causality, artificial sweetener CVD link, genetic depression liability and CAD impact, even birth weight's opposite effects on MI-AFib. Crucial for moving from correlation to cause and effect, giving confidence in identifying true mediators.
Such a powerful leap forward. So, looking ahead, what are the big picture goals for mediation research?
Well, the project compiling this evidence aimed to summarize mediation analysis applications in CAD research, compare biological versus social mediators, a critical comparison, and crucially, identify gaps where mediation analysis is underused in cardiovascular epidemiology.
And ultimately, it's about the so what, right? Translating this complex web into better prevention and treatment.
Precisely. The growing use of MER shows a move towards stronger causal evidence, a methodological best practice. Identifying where mediation analysis is underused shows this is an area of growth. A key future area is understanding the interplay between different mediator types, how environment, like air pollution, operates through biology, like inflammation. It's the intersection and cascade that matters.
What a journey. We've navigated a truly fascinating landscape today. Mediation analysis isn't just stats, it's this powerful lens for understanding the real why behind cardiovascular diseases. We've seen how everything from genes, diet, air quality, social connections creates this cascade mediated by specific factors impacting heart health in precise ways.
This deep dive clearly shows heart disease is rarely a single-cause problem. It's a complex symphony of interconnected factors. Understanding these mediating pathways allows for far more precise, effective interventions. It highlights how seemingly disparate things, a noisy street, a gene, fat around arteries, converge on critical biological or behavioral pathways.
So what does this all mean for you, listening? Consider those unexpected connections, noise pollution affecting your heart via hypertension, social connections mediating lifestyle choices. It raises a big question. If our disease pathways are so interconnected, how can we approach our own health and public health more holistically? How can we leverage these mediated insights for truly personalized, truly effective prevention?
It's a powerful thought to consider as we look to the future of heart health.